Today we're going to talk about chest pain based on the ACC 2021 guidelines. So this topic is specifically directed to people who works in the hospital, for example, residents, internal medicine physicians, cardiology fellows. So we're going to base our talk in these 2021 guidelines, and I will try to be as straightforward as possible. First, in order to talk about chest pain, before we used to describe chest pain as typical or atypical chest pain, but this carries a lot of confusion. Now we talk about like cardiac and possible cardiac and non-cardiac. Why is that? Because atypical chest pain sometimes we mean non-cardiac, but atypical could be like atypical presentation or like a cardiac chest pain. So now, what is cardiac chest pain is a substernal chest pain provoked by exertion or emotional distress and relieved by rest or nitroglycerin. Usually travels to the left arm, to the jaw, so that is going to be typical. Non-cardiac, you can see in the right side of the screen, low risk, for example, is shared, fleeting, shifting, pleural positional. High is central pressure, squeezing, gripping, heaviness, tightness, exertional stress related retrosternal. So when you have a patient who can present with chest pain, you can always describe those. Oh, do you have like a pressure like? Do you have a squeezing and gripping chest pain? So based on this, you are gonna define if the chest pain that the patient is describing is a cardiac or non-cardiac. So the next thing, like, okay, I already have like the chest pain, this patient with chest pain. The first thing like is troponins, EKG, and troponins. That is gonna differentiate between ACS and stable angina or like stable angina. But in this case, we're gonna focus on ACS straight in basic coronary artery disease, meaning like left heart cath or you can describe a diatesis. We are gonna go to the table of through to meaning like to know why is going on there. But troponin is negative, no EKG changes, but patient has like chest pain. Then we're gonna base our diagnosis based on the pre-test probability. Why is important this? Because that is gonna tell us what we need to do. Low risk is a non-cardiac chest pain, females less than 50 years old. Why? Because they are protected by estrogens. But the patient is asymptomatic. That's low risk. We're gonna see later what we're gonna do with low risk patient. And high risk patient is cardiac. It's pressure like it goes to the left, to the jaw, goes to the left arm. It's in a male more than 40 years old, or the female postmenopausal female more than 65. We're going to have a high risk of this is due to coronary artery disease. Now, low risk you can also do in the emergency department, less than 1% at 30 days risk of death. So you take like troponin, high sensitivity troponin. Is this high sensitivity troponin is a is more than 3 hours of the when the symptoms start. So you can characterize this a low risk, and you can potentially send the patient home. Or you can do like two high sensitivity components with a period in between of 2 hours. And then if it is negative, that's low risk. You can also use a hard score. If you like to use a score, less than 3 is low risk, so the patient can be discharged. What is a hard score? So basically are parameters, and you can basically ask the patient or ask yourself a history is highly suspicious or is low suspicious for having like a coronary artery disease. The EKG has huge changes in the EKG. The patient, what is the how old the patient is? For example, is more than 65 years old. More than 65 may tell you like high probability that the patient may have like coronary artery disease. Or risk factors. What is the risk factor important? To ask the patient what is the probability of the patient to have coronary disease. For example, the patient is obese, tobacco smoking, diabetes, or have like some peripheral artery disease. Initial troponins are negative, and based on this, you can basically tell if the patient has a high risk and a low risk. Remember, high score less than 3, low risk, the patient can go home. Troponin is negative, good to go, good to be evaluated as outpatient. We're gonna see how to evaluate the stable coronary artery chest pain. Now, this picture tells us basically in a summary what we need to know. In the left side is the evaluation, in the right side outpatient evaluation in the office, right? If the patient comes with a chest pain, ACS well already defined, straight to cath. Now, if troponins are negative, meaning no ACS, then we have to divide like, oh, what is the probability that the patient may have coronary disease? Low risk, no testing, discharge. High risk, invasive coronary angiography. Why high risk is invasive coronary angiography? Imagine like the patient is a smoker, is a male, more than 65, has diabetes, has peripheral artery disease. So if you do a Lexi scan, a nuclear stress test, and comes back negative, that still the question is like he still may have some disease there. So why should I spend a test when the probability of that test to come back negative is low? So meaning like if the test is negative, the test is negative, probably is a false negative test. So that's why, like, if you have high risk, you may consider invasive coronary angiography or diet test. Is intermediate, meaning like it's not high risk, it's not low risk, but intermediate, you can consider anatomical functional testing. We're going to talk about that. Now, imagine the patient goes to the office. Then you have to do like, is high risk, intermediate risk, or low risk? Low risk, you can not do anything. For example, it's a young patient complains like some chest pain. You can either do like a treadmill stress test or a coronary calcium score. I have seen many times that they do a treadmill exercise test with coronary calcium score. Why is that? Because you want to know like what is the risk factors for the patient, and you can pretty much have like work on those lifestyle modifications. Now, high risk or intermediate risk, you have like anatomical functional testing. You have here. And even here, when you have like a high risk patient, meaning like it's highly likely, you may consider go straight to the invasive coronary angiography. But based on the guidelines, you should do first anatomical functional testing first, and then go. If this is positive, go to invasive coronary angiography. So again, this. The patient comes to the emergency department, chest pain, troponin is negative, no EKG changes. So you have to base your diagnosis, your clinical judgment based on the pretest probability. Low risk, no testing required, discharge. High risk, invasive coronary angiography. In between, you need to do something else to figure out what's going on with the patient. If this is positive, meaning moderate to severe ischemia, invasive coronary angiography. This green color you see is class 1 indication for high risk or low risk, class 1. Class 1 meaning like you need to do it. Now, we already are here with a patient, came to the emergency department, pretest probability, you said like it's low, no testing. You can consider coronary calcium score. Usually we don't do because this is an outpatient workout. The patient is intermediate or high risk. You have this functional or anatomical test. What is a anatomical test? Is like a CCTA, coronary calcium. Is a oh my god, I forgot this. Is a cardiac computed tomography angiography or a functional stress test. When you as a CCTA, CCTA is you ask basically when you are suspecting less CAD or the patient is younger than 65-year old. When you ask stress testing, when you're suspecting more obstructive CAD, or when the patient is older than 65. Why is older than 65? Remember, risk factors older than 65, you are suspecting the patient may have some coronary artery disease. So, again, low risk, no testing, intermediate high risk, CCTA or a stress test. CCTA is when you are suspecting the patient may have less obstructive coronary disease. What does that mean? Less than 65. Usually those are females, right? So you are suspecting like, oh, I'm not gonna do anything in this patient. Probably the likelihood that the patient has like coronary disease is less. So I'm gonna order like the CCTA. Now, stress test, oh, probably the patient may have. So the patient is older than 65, more obstructive, CAD suspected. For example, the patient is a male more than 65. Maybe I'm gonna go with the stress test. Now, the patient is a female, 55 years old. You are not suspecting she may have like a obstructive coronary disease. So CCTA is a good test for this. Now, before continue, I want to talk about what is GD&T because that is going to impact how we are going to deal with our workup. GD&T in terms of angina basically are the medications that are going to relieve the chest pain. So most common beta blockers, nitrates such as Indur is a long-acting nitrate. Calcium channel blockers such as amlodipine, Ranexa, and also like the big one that sometimes we forget is control the risk factors. For example, the patient has diabetes, A1C is 10. Probably the patient may have chest pain and is due to diabetes. Once we control the diabetes, many times I have see like every day chest pain goes away. Hypertension, the same thing. So in order to understand and make like simplify, I have to explain you what is the CCTA workup and then like the stress test workup. CCTA, so when you do CCTA of the patient, for example, the patient is a female, 55 years old, no smoker, so you consider CCTA. CCTA can give you like three answers here. No obstructive CAD, less than 50% stenosis, discharge. Is obstructive CAD, more than 50% stenosis. Look, you can go straight to invasive coronary angiography, but when you're gonna go straight to invasive coronary angiography, left arcade, when you have like left main stenosis, more than 50%, or three vessels, 70, more than 70%, go straight. Or the patient complains of frequent angina. Oh, angina is so severe, so you go straight to invasive coronary disease. Now, it's inconclusive. You don't have those high risk features. You can either do GD&T optimize because troponins are negative. Optimize, for example, the patient hasn't been on beta blockers, so I'm gonna start beta blockers, gonna start like calcium channel blocker, or you can either do a FFRI, CT, less than A, or you can do a stress test. It's 2A indication, moderate to severe ischemia. Yes, invasive coronary artery disease. No, still GD&T. Always GD&T is good, a good thing to do. Two anti-angiols, meaning the patient has been only beta blockers, so I'm gonna add like a calcium channel blockers, or I'm gonna add a nitrate. So then, if we go through the stress test route, so what is the stress test? Stress test meaning like I'm gonna give a stressor to the heart, and I'm gonna see imaging and diagnostic tool. A stressor could be either exercise, could be either a pharmacologic. So either I increase the heart rate or I vasodilate the coronary arteries, and I have like a tool, a diagnostic tool to see what is going on with the heart. I can use like a MRI. I can use a PET, SPET, echocardiography, or EKG. EKG is two-way. Why? Because if the patient is in the emergency department and is hospitalized, I better make sure the patient has coronary artery disease. Well, that's why like Lexiscan or stress test PET is most likely preferred. So then we have like three options. Patient has mild ischemia, again, optimize GD&T. If the patient has moderate to severe ischemia, more than 10% of ischemia, uh, again, we can optimize always, but we can go through invasive coronary angiography, or or no, or we decided to optimize medication. The patient is inconclusive, you can go either to CCTA or invasive coronary angiography. This is clinical judgment. Means if the patient has a high risk factors to have like some coronary disease, I would prefer to invasive coronary angiography. But imagine like the patient is a female, probably you are not suspecting to find like any coronary artery disease, so probably CCTA is a good way to go. Now, acute chest pain. Now, like we understood what is the pathways of like CCTA or stress test, we're gonna talk about what we're gonna do when we find like a patient with a chest pain. Um, the patient has never seen a cardiologist, a heart doctor before. That's what you're gonna ask. That's another important question. Have you seen a heart doctor before? Have you had like any stress test, any like cardiac workup before? The patient tell you no. So then, no, you have like either class one CCTA or stress test. We already review what is the indication of CCTA or stress test. CCTA, you have like a low suspicion that the patient may have coronary disease. Usually it's less than 65, it's a female. Stress test, patients have like high risk factors. So you are gonna go, and then you're gonna follow like the pathway that we already talked about. The patient had a prior test, recent negative test, you can discharge. Patient has inconclusive stress test, you can do like a CCTA. If the patient has like a prior moderate to severe ischemia, then you can go to invasive coronary angiography. So it's straightforward. Now, it's important to understand what is warranty period. As the car has a warranty period, the stress test also has a warranty period. What I mean in warranty period, like is low likelihood that this coronary artery disease progress over time. So usually if you have like an anatomy test, it's 2 years. If you have like a stress test, it's 1 year. Anatomy test is like invasive or CCTA. Now, prior test, yes. The patient had like a less than 1 year uh, abnormal stress test here. Abnormal stress test, so you go with invasive coronary artery disease. But if the stress test was normal, negative, less than 1 year stress test, or has like a left heart cath within like 2 years, you can discharge the patient. You optimize GDNT and you can discharge. Why? Because like the warranty period is there. Now, inconclusive, you can go like CCTA and then follow the path this. Now, patient, the same patient, present with acute chest pain, but now the patient has a known CAD. Known CAD tell you like prior MR, revascularization, non-obstructive CAD, or invasive, uninvasive coronary angiogram or CCTA. So if the patient has like a known CAD, at that time, non-obstructive CAD, non-obstructive CAD, you can do a CCTA. This is to a commendation, less than 50% stenosis. Or if the patient has obstructive CID, you do a stress testing. High risk features, the same thing, you go to invasive coronary angiography. Now, why is it important this? For example, the patient present to the emergency department, acute chest pain. You have like a left heart cath done like within 1 year, and there is like a 50% stenosis that wasn't stented. Then you can either choose doing a stress test. But if that has higher features of having like a higher risk features of CAD or frequent angina, you can go invasive coronary disease. Now, if the patient has like a left heart cath recently, like meaning like within 2 years of anatomical testing, you can do like CCTA and then proceed with the workup, or you can do a stress testing. You can see it depends on every case. Now, if the patient has extensive plaque, the stress test is preferred. Why? Because the CCTA probably is not going to be a good tool to perform. We already talked about in the emergency department. Now in the office, the patient comes to the office. The patient comes with a stable angina, stable chest pain. The patient didn't have any prior a cardiac workup. So you divide like a pretest as we talk. Pretest probability not test recommended, or you can do like a exercise stress testing or CAD, a coronary calcium score. Now, if the patient is intermediate or high risk, CCTA class 1, or stress testing. Stress testing meaning Lexi scan, MRI, stress echo, or exercise EKG. It's 2A. It's better to do Lexi scan when you have like a high risk probability. For example, if the patient is diabetic, is a male, more than uh, 65 or more than 50 years old, is a tobacco user, is obese, Probably with the exercise stress testing is not enough, because if the exercise stress test is negative, probably it's a false negative study, and then the patient continue with chest pain. I already waste one diagnostic tool, so I have to go straight to I have to do like something else. Now, what happens when the patient has a non-coronary artery disease? Non-coronary artery disease, non-obstructive CAD. I have to optimize GDNT, and then if the symptoms persist, I can do either stress testing, CCTA, and in the CCTA, if the FFR or this lesion is less than 80%, point A, or in the stress testing is moderate to severe ischemia, I do invasive coronary angiography. But if no, probably the patient has like a still microvascular disease, why it's called INOCA. So again, lifestyle modifications. For example, if the patient is A1C of 10, probably I have to improve the A1C, and it's going to improve the chest pain. Now, the patient has obstructive coronary disease more than 50%, GNT optimization, high risk features that may more than 50%, or the FFR was like less than 80%. In basic coronary artery disease. CCTA can be still choose 2A recommendations for the patient who has stains more than 3 millimeters or prior coverage. Why is that? Because the stain more than 3 is highly likely to have like an instant restenosis. Again, GNT here. The patient doesn't have like those high risk features. I can choose like stress testing, and then no ischemia, moderate ischemia, invasive, mild ischemia, GDNT, always GDNT. Remember, always when you evaluate a patient, GDNT, beta blockers, calcium channel blockers, Ranexa or nitrates, and also controlling the risk factors. For example, stop smoking. I have seen many patients who complain of chest pain. After they stop smoking, the chest pain goes away. So, in a nutshell, chest pain evaluation is a frequent cause of like a ED visits. It's easy when you understand what we are gonna do. Chest pain in the emergency department, what is you have classified is this is ACS. How? Troponin CKG. Troponin CKG positive, invasive coronary disease. Troponin CKG negative, pretest probability. Pretest probability is high, probably invasive coronary disease is a low, nothing, discharge home, GDT. In the middle, we have to do some anatomical or a functional test. Anatomical CCTA when I suspect less coronary disease, or the patient is less than 65. It's a female CCTA. Why a female? Because they are protected by estrogens. Patient is postmenopausal, probably may have like some more risk factor for coronary disease. Now, functional Lexis scan, stress echo, stress MRI, if that comes back positive in basic coronary disease. Now, the patient warranty period, don't forget warranty period. And a functional test is 1 year, anatomical test is 2 years. Why is important? Because the patient comes with chest pain, recent Lexis scan is negative, a patient can be discharged to home. So let me know if you want me to talk, you want me to review other topics. Thank you and subscribe. Bye bye.